Position of safety. Hi, my name is Connor McSweeney, and I'm a fourth-year medical student at the University of British Columbia. Today, I'll be doing a presentation on the position of safety, a common splinting position for prolonged immobilization. So what is the position of safety? The position of safety is the safest hand position for prolonged immobilization. It consists of wrist extension of 10 to 45 degrees, MCP flexion of 60 to 90 degrees, and full extension of the PAPs and DIPs. Why is the position of safety important? Well, prolonged immobilization of the hand can lead to joint stiffness and contracture that can cause loss of function and deformity. The position of safety minimizes joint stiffness, contracture, and loss of function post-immobilization. Why is it that we get such joint stiffness with prolonged immobilization? The answer is ligaments. Ligaments are bands of connective tissue around your joints. They connect bone to bone to give joints support and limit their movement. Ligaments are able to stretch and undergo tension. Here we can see an electron micrograph of ligaments that are relaxed in the top photo and ligaments that are under tension in the bottom photo. This concept of the dynamic nature of stretching and relaxing ligaments is the basis of the position of safety. We want to maximize tension and elongate the ligaments when we immobilize the hand. If we immobilize in a position where the ligaments are relaxed, we are at risk of shortening the ligament and losing range of motion post-immobilization. Now let's go through each joint and see why we keep it in the position that we do for the position of safety. First, we have the wrist. The wrist is composed of many bones that are prone to developing stiffness. In the position of safety, the wrist is in 30 to 40 degrees of extension. This is the position of function for the hand. So post-immobilization, we will still have maximal hand function, even if stiffness has occurred. The wrist is also very susceptible to carpal tunnel syndrome, which is compression of the median nerve when in a flexed position. Therefore, we try to avoid this. The MCP joints are diarthrodial joints, which means the articulating bones are separated by a fluid-containing joint cavity. This arrangement permits for substantial freedom of movement. They are the most structurally complex type of joint and are the most likely to develop uncomfortable and crippling dysfunction. Nearly all joints of the limb and most joints of the body fall into this class. These are in comparison to fibrous joints like the sutures of the skull and cartilaginous joints like rib cartilage. The MCP joints have flexion and extension of 0 to 90 degrees. Their lateral movement is based on their position. In extension, there is a greater degree of lateral movement compared to when the joint is in flexion. You can see this for yourself. When you extend an MCP joint and move that individual finger from side to side, there is a large amount of lateral movement. When you flex the joint, movement is pretty limited. This is due to rein-like collateral ligaments on the side of this joint. These rein-like collateral ligaments undergo different degrees of tension due to something called the cam effect. The cam effect is a biomechanical term. A cam is a rotating or sliding piece in a mechanical linkage used especially in transforming rotary motion into linear motion. So, when an oblong object, like the red structure in this diagram, is rotated around an axis, there will be displacement of any structures placed against it depending on the position of the oblong object. This can be seen in our MCP joints. A metacarpal head diagram can be viewed at the top right of the screen. The articulating surface of the metacarpal head is much further from the center of the bone on the volar aspect, which is inferior to this photo, compared to the position when the joint is in extension and the proximal phalanx is towards the right of the diagram. This is an example of the cam effect in action. The collateral ligaments of the MCP joint originate on the metacarpal head and insert on the base of the proximal phalanx at the volar side. When the MCP joint is in extension, the ligaments are relaxed and loose, which allows for that maximal medial and lateral deviation. When the MCP joint is in flexion, the proximal phalanx is against the furthest part of the metacarpal head, and due to the cam effect, the ligaments are stretched and tight. This causes limited lateral mobility. Therefore, in the position of safety, we immobilize the MCP joint in 90 degrees of extension. Next, we have the PIP joints. The PIP joints are diarthrodial hinge joints with 5 degrees of flexion to 110 degrees of hyperextension range of motion. They have minimal lateral motion. The PIP joints have many stabilizing ligaments, including the proper and accessory collateral ligaments, 1 and 2 in the diagram, the volar plate and check rein ligaments, as well as the capsule. The proper and accessory collateral ligaments are under static tension throughout the entire range of motion. In other words, in flexion and extension, they have the same degree of tension along the ligament. Therefore, they have little impact on the proper position of safety. However, the volar plate and check rein ligaments do have an impact on the position of safety. The volar plate lies on the volar aspect of the joint and prevents hyperextension. The proximal aspect of the volar plate of the PIP joint is free and attaches to the proximal phalanx by check rein ligaments. This allows for the proximal aspect of the PIP joint to slide during flexion and extension. In immobilization, if the PIP joint is in flexion, that proximal sliding volar plate would be flush against the volar lateral ridges of the proximal phalanx. This can allow for fibrous adhesions to the check rein ligaments to develop, which would prevent the volar plate from being able to slide distally with attempted extension. This is why we immobilize the PIP joint in extension, to prevent any fibrous adhesions of the check rein ligaments and volar plate to the proximal phalanx. Lastly, we have the DIP joints. The DIP joints are diarthrodial hinge joints with 0 to 60 degrees of range. They also contain many stabilizing ligaments, including the proper collateral ligaments, the accessory collateral ligaments, the volar plate, and the capsule. The proper collateral ligaments, volar plate, and capsule are all under static tension throughout the range of motion of the DIP joints, and so once again they have little impact on what the proper positioning for the position of safety would be. The accessory collateral ligaments are fan-shaped fibrous units. They arise from the palmar portion of the head of the middle phalanx and form the palmar edge of the true collateral ligament. This ligament is loose in flexion and is tight in extension. Therefore, we immobilize the DIP joints in extension in order to maximally provide tension for the accessory collateral ligaments. So now, when we look at all of those joints together, we have the position of safety. So the DIP joints will be in full extension to ensure the accessory collateral ligaments remain fully extended. Next, the PIP joints are in full extension to ensure that there is no adhesions of the check rein ligaments to the volar plate. The MCP joints are in 60 to 90 degrees of flexion to ensure that the ligament is maximally stretched due to the cam effect. And the wrist is in 10 to 45 degrees of extension to maintain the position of function and prevent carpal tunnel syndrome. The position of safety also favors the weaker motions of the MCP flexion and IP extension in order to ensure that these ends of the range of motion are maintained post-immobilization. Overall, the position of safety maintains each joint in a position where the soft tissues are maximally lengthened. This means that the position of safety maximizes post-immobilization hand range of motion. So when do we use the position of safety? Splinting of the hand in the position of safety is done for many different hand injuries. These injuries can include fractures, though many exceptions do exist, flexor tendon injuries. It should be noted that extensor tendon injuries are splinted in a high 5 splint with the MCPs extended. Nerve injuries, to help prevent any contracture that might occur, burns, preventing any scar contractures, and with corrective splinting. That concludes our presentation. Thank you for listening, and I hope that you learned something about the position of safety and proper hand immobilization.